Hello, and welcome to the Stroke Special Interest Group Student Corner for the Academy of Neurologic Physical Therapy. My name is Arko Paul. I am a neurologic clinical specialist and a faculty at Radford University Carilion, which is located in Virginia. I have with me Kristen Hammack here, who is a student of physical therapy at Wingate University in North Carolina. Welcome, Kristen. Would you like to introduce yourself?
Thank you. Like you said, my name is Kristen. I am a third-year physical therapy student at Wingate University. It's located just outside of Charlotte, North Carolina. And I graduate in December, which is about a month from now. So can't wait.
Thank you. And thanks for joining this discussion. So we're here to talk about high-intensity gait training. And we're going to talk about a few practical applications for the high-intensity gait training clinical practice guideline that just recently came out. So let me share the screen at this moment. So Kristen, I know you were talking to me a while back about a patient that you were interested in applying this high-intensity gait training on. Would you like to describe your patient a bit?
Yeah, I would love to. I think we have a slide on it.
Yes.
So the first patient, it's a 66-year-old male. He came to us at about 7 months post-stroke to the outpatient clinic. He had some left-sided hemiparesis, left-sided deficits from his stroke that were mostly impacting his ability to walk. So his main goals were to improve his ability to walk. And then we've got some videos of him walking actually on the next slide we can take a look at.
That's great. Yes.
Okay, go ahead.
Great. And I know you did some initial assessments on this patient. So if you want to describe your assessment on this patient.
Yeah, so obviously we can kind of see from the videos that he is a little bit slow when he's walking, but that he is able to walk with and without the cane. Obviously he looked a little bit more stable when he used the cane, but he was able to walk fairly well without it. When we did the 6-minute walk test, which we'll talk about a little bit later, he wasn't really able to walk for long distances and was always saying that he needed to rest. So we talked about him walking slow. We actually have the numbers for that here. So his self-selected pace was at 0.69 meters per second, and his fast pace was at 0.77 meters per second. So we note that that would classify him as the limited community ambulator, according to the gait speed chart. Because we really would like their gait speed to be above 1.2 or so to be considered a normal gait speed. So he is a little bit below the normal range. He's still within the range that puts him at an increased risk for falls. We can also see here on the 6-minute walk test for endurance that he was able to walk 196 meters and he needed to stand and rest during it. I believe that the norms for patients with stroke, it's about 300 meters during the 6-minute walk test. So he was about a third less than the norms for patients, but overall not terrible endurance. And then we can also see his heart rate at the beginning, which was 58, and his heart rate at the end was 84. So there was not a huge change over the course of the 6-minute walk test, which we'll talk about a little bit later. And then we also have his blood pressure readings. As you could see, kind of with the use of the cane, his balance wasn't the best. So we went ahead and did a Berg balance scale on him, and his score was 43 out of 56. The cutoff score for that is about 45. So he's just within the range that indicates that he would be at a risk for falls. So we just want to keep that in mind with anything we do with him, provide safeguarding, make sure we're being careful.
Yeah, sure. Very good. And I think your patient is, you can apply the concepts and recommendations of this high intensity gait training fairly well in this patient. So before we look at how we're going to apply this practice guideline on your patient, let me provide you a brief overview of some of the summary statements that I think is most relevant for your case. So this clinical practice guideline is actually known as a CPG to improve locomotor function following chronic stroke, incomplete spinal cord injury, and brain injury. And that's the actual name of this clinical practice guideline, and it's freely available to readers in this Academy's Journal of Neurologic Physical Therapy. And that is the link to that practice guideline. I wanted to just provide you some of the key summary statements that I thought is most applicable to your patient's case. So firstly, as you already know, the primary goal, the primary purpose of this practice guideline is to be able to improve walking speed and walking distance. In other words, walking tolerance. So in order to be able to perform that, they recommend that clinicians should perform gait training at least at moderate to high intensity levels, which translates to 65 to 85% of heart rate max or 60 to 80% heart rate reserve. And they also recommend that clinicians should perform gait training using virtual reality environments or virtual reality devices in order to improve walking speed and distance. And then they also provide a few other recommendations where they say clinicians may consider engaging in lower extremity strength training, depending on the level of strength of the patient, to be able to, again, improve gait function. And then they say patients may engage in cycling or recommend stepping type activities, again, at higher intensity levels in order to improve walking speed and distance. And then they mention that clinicians may consider performing circuit training where they can use some combined strategies targeted at improving balance, strength, and aerobic type exercises in order to, again, improve those gait function. And then depending on, again, the needs of the patient, clinicians may consider engaging their patients in static or dynamic non-walking type of balance activities, but as long as they are coupled within virtual environments or within augmented reality environments. So those are some of the key summaries that I thought might be helpful. Now, there are other recommendations in the CPG, and I would recommend you to look at all the details of the practice guideline, but these ones I thought were most likely applicable to your patient. Now, before we look at your patient again, I want to quickly mention some of the limitations and caveats when we apply this practice guideline. So as you already know, this practice guideline was developed specifically for post-stroke individuals who had stroke at least 6 months back. So we're talking about chronic stroke here. And then, as you already saw, the main gait outcomes or walking outcomes that they looked at were gait speed and gait distance. So it may or may not apply to other aspects of gait or non-gait functions. And then the research that this practice guideline is based out of, they have used individuals who were fairly well in their ability to walk. And so they did not need much of physical assistance or they did not have any severe balance issues when walking. So it, again, may or may not apply to individuals who have very limited ambulatory function, or if they need a lot of assistance to walk, or if they have severe gait-related balance problems. So we may need to be able to adapt the recommendations of this practice guideline when we have such patients in our clinic. And lastly, although their statements are applicable for other types of neurologic patients like spinal cord injury or traumatic brain injury. But when you look at the evidence came out primarily from post-stroke individuals. So we'll have to be cautious about using their recommendations when we have spinal cord injury, especially incomplete spinal cord injury or traumatic brain injury patients. Additionally, the Academy has provided us with some examples of strategies that we can use when we are trying to implement these recommendations in our clinic. And in order to be able to use it effectively, they have provided us this chart where we basically look at some gross gait subcomponents of our patient, and the way they have divided these subcomponents are these 4 things here. So the first one, if you look at the left column, is limb advancement, and then there is stance control, and then propulsion, and then finally balance or postural stability. So so what they mean by limb advancement is a patient's ability to be able to advance the swinging leg far enough so that they prevent any loss of balance or falling to be able to proceed in their intended direction. And then stance control is defined as the patient's ability to prevent any limb or trunk collapse while they are standing or walking. And then propulsion is, as you can imagine from the word, is the patient's ability to move his or her body forward in their intended direction of movement. And balance, as you can see, is defined as the patient's ability to maintain upright postural control while they're standing or walking. If we have to apply the recommendations of this practice guideline, we have to think about what is the primary impairment, or which gait subcomponent we think is impaired when we look at our patient's gait. And then depending on which one we choose, this chart provides some specific examples of gait interventions that we can engage our patient in. So for example, if we think limb advancement is the main problem for our patient, we can start by physically assisting with advancing the patient's leg. And then slowly, as the patient gets better, we can try to remove that assistance and have them practice more with trial and error, see if they become more and more successful. And then finally, when they are getting better, we can increase the challenge by then adding weight or resistance. For example, we can add the leg weights, or we can use TheraBands to provide resistance. And then we can also engage them in different types of gait activities, which can include ramps, stairs, and curbs. So now if we think stance control is the main problem for our patient, then of course we'll have to then provide some sort of body width support, some sort of unweighting when we are engaging them in any kind of gait activity. And then we might have to start by providing some percentage of unweighting. And then additionally, we might have to provide some physical assistance to the trunk or the leg. And this type of gait training could be performed either over ground or using treadmill. And then as the patient gets better, we can try to reduce the unweighting to the point that we can just keep the harness in place without providing any unweighting as the patient gets more and more successful. And then to challenge the patient more, we can then add on weighted vests. We can have them walk on uneven or compliant surfaces. So we can use those ways to provide more and more challenge in order to be able to increase the intensity at which we want to provide gait training to our patient. Now, if we think propulsion is a problem, then the main purpose of our gait training there is to be able to improve or increase patients' gait speed. And so we might have to start by providing some physical assistance in order to help them advance their gait device. If they're using any, again, depending on the level of function, we might again have to look at unweighting if needed in order to provide that gait training in a safe environment. But then as the patient gets better, we can remove any assistance that we're providing to the device, or we can remove any unweighting that is needed when we're having them try to walk faster and faster. And then ultimately, we can increase the intensity of that gait training by having them engage in speed bursts with time trials where they will need to walk faster, and that might increase the intensities of that gait training towards our goals of 60 to 80% of the heart rate max. And again, we can use ramps, stairs, or curbs to again increase the intensity of gait training. And finally, if we think balance is the main problem, which is limiting a patient's gait abilities, then we might have to start by providing physical assistance to stabilize their gait as we engage them in gait training. And then we can similarly take out assistance slowly. And in such a case, we can also have them engage in circuit training type of interventions as recommended by the practice guideline to also try to improve their balance. We should ideally try to do those within virtual reality type environments to make it more effective. And then when the patient gets more and more successful, we can add more and more challenge by again having them perform those gait activities on uneven surfaces. We can try to have them perform gait activities while we provide random perturbations in different directions to try to see if they can remain steady against those physical perturbations. So those are some example strategies of how we can implement these recommendations that are provided by this practice guideline. But again, as you see at the very right column here, the goal is to take the patient to that higher level of intensities in order to reap the benefits of gait training. So with that brief overview, would you like to then take a stab at some of the interventions that you think might be applicable to your patient?
Yeah, of course. So we already talked a little bit about how his speed was pretty slow. So I think one of the main things we would want to focus on with this patient is that propulsion column that we talked about. We know that he's able to walk without the assistive device. So I think we would try to push him to increase the speed without the assistive device, assuming he's still safe with that. Then we can kind of move into that third category where we're kind of doing some speed bursts on varying surfaces, ramps, curbs, things like that. He seems to be pretty functional. So I try to keep the gait training to be as functional as possible. So try to simulate real life situations, walking over, grass, uneven surfaces, things like that, where you might have to step over, going upstairs. So you can see from his scores on the 6 minute walk test that his heart rate did not really increase all that much during that 6 minutes of walking. Some of that could be from standing and needing to rest. Some of that could just be he wasn't exerting himself all that hard. And then you were kind enough to put the heart rate max range up there for us.
Help you.
Thank you. So we can see what our goal is compared to what he achieved on that 6 minute walk test. And that kind of tells us that he's somebody that we're really going to have to push in order to increase that heart rate. In my experience, it can be a little bit challenging to increase a patient's heart rate, especially when you're keeping it functional. I think some of the better ways to kind of challenge them involve ramps and stairs, things like that, which is still functional, but it's also creating a bit of a challenge for them and trying to get that heart rate up and really increase the intensity. So I think that's kind of where we would start in terms of propulsion. And again, we talked a little bit about the balance on the Berg balance scale, saying that he was still within that fall risk category. So we might want to address the balance. Like you talked about, the CPG says that you can do circuit training. And so ideally, if we were to do circuit training with him, we would try to incorporate balance. We would try to incorporate some more aerobic conditioning to see if that would assist in increasing his 6-minute walk test. And then also some strengthening, because the strengthening is going to help to improve his gait mechanics and along with the stability when he's walking. And again, that strengthening was at greater than or equal to 70% of the 1 rep max, which again is a pretty high intensity. So kind of the same idea. We're kind of driving that intensity across the board in order to get the neuroplasticity effects. You could also try to use virtual reality training for some of the balance if you have access to that. I personally do not have access to it, and I've never tried it. I don't know if you can speak to that at all, but
Yes. So yeah, it is dependent on how much access you have in your setting to these virtual reality devices or the virtual reality environment. But if you don't, you can at least have your patient engage in different types of circuit training interventions, which can include balance interventions, because it seems like he probably would benefit from some sort of balance training while he's engaged in gait training, high intensity gait training. And I totally agree. This is perfect. You hit the nail in the head. Propulsion is probably the most important deficit for your patient, as he is clearly able to have appropriate or adequate limb advancement. His stance control is also not a problem. So I would lean towards improving his propulsion and maybe his balance, dynamic balance, as it relates to gait type activities. So yeah, and I think he is currently at a level where he can perform gait on his own. So now he's probably at the point where he needs to be challenged more. And as you correctly mentioned, we probably have to find some safe ways of having him do some speed gait type of activities. So you might have to keep him safe while he is doing that. And ultimately, the goal is to increase his heart rate to those moderate to high intensity levels, to be able to reap the benefits of neuroplastic processes, to improve gait function, specifically speed in your case. So yeah, I would go for improving some of the strategies that are recommended for improving propulsion, and then trying to achieve higher and higher intensities. And I know it is difficult, and it might not happen soon, but I think with weeks of training, there is a good chance. Looking at the current function of your patient, it seems like he should be able to achieve high intensities of gait. So that's good. Thank you very much for these lovely discussions. I hope other students will find this discussion on high intensity gait training useful. Thank you very much again for talking to me.